up to the ileum is also possible, but then in that case conately be involved. Okay, it cannot be isolated ileal involvement. Right. Next organ. It's an opened section. There are these multiple rugae that you can see. Stomach. What is this? Yes. What you can say about this on this is that there is a very large irregular ulcer with hemorrhagic base, has irregular nodular margins. So this irregularity, this large size, it's what is suggestive of a malignant ulcer. You can only say it is an ulcer, it's a large ulcer, but the probability of it being malignant because of these features of being irregular, having hemorrhagic base and having nodularity is very prominent. So you can say organ is the stomach section is open and reveals a large ulcer, irregular walls, hemorrhagic base, multiple bleeding points suggestive of a malignant gastric ulcer. Okay, right. Here you see an open section of the entire section of the colon. The entire section has been opened up and you see large multiple ulcerations, hemorrhages and granularity throughout the section of the colon, suggestive of ulcerative colitis. Okay. Yes. Anything else? Anybody else would like to attempt this? What is this? This is one. There is one here. There is one here. This is again the colon. Multiple colonic polyps. Okay. So polyposis coli, and they can ask you many questions. Can they be? These can be adenomatous. Can this be malignant? What are the questions? But these are relatively rare. What you are likely to get are the other specimens which I have shown you, which are much more common. Okay. Right. This I have shown it to you. The answer is right here. This is a cut section of the brain, and what you can see within the brain is that there is a very large area of hemorrhage. So this is an intracerebral bleed. So questions can be, what are the risk factors? How will you diagnose it, and how are you likely to manage it in the initial phases? Risk factors would be hypertension, coronary artery, atherosclerosis. Okay, so these are the things that you need to take care of. Okay, now I am going to go and show you. These were gross pathological specimens that we saw, and I am going to show you an example of a very few microscopic slides from which I expect you to give me some answers. Right? Anybody? The arrows are marked for your. Yes. So this is very classical, the very hallmark of the elongated elliptical gametocytes of Plasmodium falciparum. Okay. So these are very characteristic and they are most likely to be kept as part of a microscopic slide. It is so characteristic. So these are elliptical gametocytes of Plasmodium falciparum. So questions can be, how do you treat a patient with this condition? So you will start with injection quinine or one of the artemisinin derivatives. Okay. So or they may ask you, in a 8-month pregnant lady with this condition, how do you treat? You will definitely treat only with quinine. You cannot give anything else. So the questions would depend upon what you are able to identify the side as. Right. We go to the next slide. Right. Right, this is, no, she is absolutely right. It's a hypersegmented neutrophil. A single neutrophil with so many segments. Diagnosis? Megaloblastic anemia. If you are able to see even a single hypersegmented neutrophil, it is enough for you to make a diagnosis of megaloblastic anemia. So this is an example of a hypersegmented neutrophil. Okay, then questions which can be asked, what are the causes of the condition? Important causes would be folic acid deficiency, B12 deficiency. How do you diagnose it? By peripheral smear and by doing serum levels if it is available, and treat according to the cause identified. Right. Yes, this is a sputum smear showing multiple acid fast bacilli. The whole smear is studded with these acid fast bacilli. So they can ask you, identify the stain, identify the organisms. You must be able to write Zeal-Neisel staining, acid fast bacilli. They can ask you, can you name 3 organisms which exhibit this property? So yes, Mycobacterium tuberculosis, Mycobacterium leprae and Nocardia. 3 very important organisms which exhibit the property of acid fastness. Okay, right. Yes. A little difficult. If you can see, you have these large cells which are promyelocytes, which are metamyelocytes, CML, chronic myeloid leukemia. If you see these cells, they are not very immature. They are not myeloblasts. They are more differentiated. So it's a smear showing chronic, a smear from a patient of chronic myeloid leukemia. Okay, right. This is a macrophage. Let me make life easier for you. This is a macrophage. This is another macrophage. There are some things which are inside, some things which are outside. Patient has come with prolonged fever. Patient has come with prolonged fever of 4-month duration. These are classical LD bodies. Okay, Leishman, Donovan bodies which are seen in patients with Kala-Azar. Okay, so this is a macrophage which is studded with LD bodies which are both intracellular as well as you can see some of them are actually extracellular. So this is the hallmark of Kala-Azar. So then they can ask you questions like how do you treat it, what is the first line drug, what are the complications with Kala-Azar. So these are some questions that you need to know. Okay, right. Now we come to the last and a very interesting topic of ECG interpretation. Some of these ECGs you will find, I didn't know, I was expecting such a large crowd, so I would not have written the diagnosis, but in some it is written, in some it's not written, so please you can go ahead and enjoy whatever is there. Right. Approach to an ECG, it's almost the same. You must spend some time in detailed evaluation of the ECG. Look at the ECG strip which is kept in front of you. There sometimes they may keep the whole ECG strip, sometimes they may only keep that lead which is showing an abnormality, so you need to focus on what it is there. Always read the ECG in a methodical fashion, identify all the abnormalities, then give your full diagnosis, and then of course you have to answer questions. Okay, simple things to go by: calculate the heart rate first, then identify the rhythm, determine the axis. After you have done these three things, look at the waves: the P wave, the QRS complex, the T wave, the U wave. Then look at the intervals, the PR interval, the ST interval, the TP interval, and then you identify the abnormalities. So if you go through this protocol, you are not likely to miss anything. Okay, so I think you all know this. There is a P wave, there is a QRS, there is a T wave, there is a PR interval, there is a QT interval, there is an ST interval, and then there is a TP interval. You may see U waves. For calculating rate, you need the RR interval. You will also need the PP interval to identify the rhythm. You will also need to see the association between the P wave and the QRS complex to again identify the rhythm. Okay. Common ECG abnormalities. Okay, here if the answer is there, what you can see is that there is just a slowing of the heart rate. If you see, let us take lead V1, let's take lead V2. There is a P wave, there is a QRS complex, there is a T wave. Each of the P waves is followed by a QRS complex and a T wave. The only thing that is abnormal is that the RR intervals are very long. So, and if you calculate the heart rate, it is about 48. So, the diagnosis is sinus bradycardia. Questions: what are important causes of sinus bradycardia? Okay, it could be physiological, like in athletes. Okay, in obstructive jaundice, in patients who are having hypothyroidism. What else? Drugs like beta blockers can slow down the heart rate. Then sinus node dysfunction can sometimes present with bradycardia. So that could be a cause. But of course then there should also be sinus pauses or sinus arrests, which this does not have. So this just is a case of sinus bradycardia. Simple case of sinus bradycardia. Right. This ECG, please. Somebody, anybody. What is the heart rate here?
Sinus tachycardia.
You can't call it sinus tachycardia. Can you see the P wave? This is just supraventricular tachycardia. The heart rate is much more than for to be called sinus tachycardia. Sinus tachycardia would be less than 120. Here it is much more than that. Okay. What else can you see? There are some diffuse STT changes here. Why are these STT changes here? They are secondary because of the increased heart rate. They have no relevance per se. They are just related to this increased heart rate. So what you can see is sinus tachycardia. If you see, you have these STT changes, but the most important thing is that there is a very significant increase in heart rate. Okay. How do you manage supraventricular tachycardia could be the question. So carotid massage and drugs, adenosine, no, not amiodarone, adenosine, diltiazem to slow down the heart rate. These things can be given. And if the patient is in cardiovascular compromise, then you need to DC shock with a low voltage. Okay. So these are questions that can be asked. Right. Next question. Next question. What is happening here? There is this RR interval. There is this RR interval. Yes, it's a very variable RR interval. What else? Where is the P wave, doctor? Where is the P wave? There is no P wave. You really cannot identify a P wave. So, not identifiable P wave, variable RR interval suggestive of atrial fibrillation. What else is this? There is one complex here. There is one bigeminal pattern which is seen, escape. But otherwise, if you see this long lead which is there here, V1 has been kept as a long lead, there is a very variable RR interval. Okay, so you have atrial fibrillation with a rapid ventricular response, irregular heart rate, no P waves, and these are some aberrantly conducted waves which are there. Right. Next, I have marked these for you in the red, though they are not very clearly visible. This and this. What is happening here? And this is another lead. This would be lead 2, this would be lead V1. What is happening here? Which wave is this? Which is this wave? P wave. This is lead V1. What is happening to the P wave here? No, it is not inverted. In the V1, you are expecting no, it is atrial enlargement, left atrial enlargement. What is happening is the duration of the P wave is increased. Left atrial enlargement is seen by duration of P wave. Okay. So here you find that in lead 2 it is going to be a wide P wave, and in lead 1 the negative deflection is increased. So this negative deflection of the P wave is increased. So this is a patient showing left atrial enlargement. Common causes of left atrial enlargement: mitral stenosis, mitral regurgitation. Two very important causes of left atrial enlargement. Okay. This is another thing on a fuller form. If you can see here, you have the negative deflection, prominent negative deflection here, and you have these very wide P waves here. So this is what is called P mitral, which is suggestive of left atrial enlargement. Here, yes, yes, that was an atrial enlargement. This is evidence of left ventricular hypertrophy. Look at lead 2, look at lead V5, V6, and you calculate the negative deflection component R in V1 plus S in V2. It should in S in V6 should be more than 35, and R wave more in lead 2 more than 25 isolated, with significant strain pattern in the lateral lead. So patient having left ventricular hypertrophy with associated strain pattern. So questions can be asked: what are the long-term complications of this condition? Nephropathy, left ventricular hypertrophy, retinopathy, chronic hypertension, all target organ damage suggestive of which are due to chronic long-standing hypertension. Okay, it can also occur in patients with aortic stenosis. Remember, there can be many causes of left ventricular hypertrophy, but if hypertension is a cause, then what are the underlying, what are the other complications likely to be? Right. This is marked here for you. Yes, P waves are all right, PR interval is all right. What you can see here in lead V1, V2, V3, V4, prominent QS pattern with ST segment elevation and associated T wave inversion suggestive of, you can't say old, fully evolved anteroseptal MI. Why? Because ST segment elevation is still persisting. Had it been old, ST segment would have returned to baseline. So fully evolved anteroseptal wall myocardial infarction. Also you must note that whether there are any reciprocal changes in the other leads, but here reciprocal changes seems to have settled down by this time. Right here, yes, acute inferior wall MI. This is a patient of showing ST segment elevation in lead 2, lead 3 and AVF, and notice the significant reciprocal changes in the anterior leads suggestive of acute inferior wall myocardial infarction. Okay, here again a patient with acute anterior wall MI, but remember here Q waves have not developed. Okay, in the first we saw it was fully evolved. Here it is acute. Why? Because the ST segment is very still elevated and Q waves have not yet appeared, and there is also again reciprocal changes in the inferior leads suggestive of acute anteroseptal wall acute anteroseptal myocardial infarction. Okay, this answer is here, but if you see here what is happening is, just look at the red ones which are the P waves. So we will start from here. This is the PR interval, then this is the PR interval, then this is the PR interval. What is happening to the PR interval? It is progressively increasing, and after this P wave there is no QRS, so a beat is getting dropped. So this is a Morbid's type type 1, second degree block type 1. Okay, so this is progressively increasing PR interval followed by a drop after a P wave. So this is a Mobitz type AV block. Okay, there it was a type 1 block, here it is a type 2 block. There are 2 P waves and there is 1 QRS. So for each P wave, each alternate P wave is not getting conducted. So this is a 2:1 kind of a block. Okay, so they can ask you questions like what are the common scenarios in which you see it and how are you going to manage these patients, what are the complications likely to be. So these are the things that you can ask. Right, here the P wave is very short. So what are the causes of a short PR interval? Commonest would be a WPW syndrome. Anything else? There is another syndrome. Okay, what else? LGL. What is LGL syndrome? That also can have a short PR interval. But here you can see the prominent delta wave, which is an upslur, which is a slurred wave which is seen on the upstroke of the QRS complex. So if you have a short PR interval with this prominent upstroke, it is called a WPW syndrome. Okay, another question. What is this? Look at this lead here. Look at this lead here. Sorry.
Inversion of the T
wave is inverted, okay, but that is not the primary abnormality. Look at the QRS duration, doctor. What is happening to QRS duration? Broad QRS. So broad QRS suggestive of a bundle branch block. So is this right bundle branch block or is this left bundle branch block? The morphology of QRS will tell you. Yes, in lead 1 you have an RSR pattern, okay, with broad QRS. B2 is showing even better RSR pattern. So it is a right bundle branch block. What about this? This is a left bundle branch block. If you see the morphology of the lead in lead V5 and V6, broad QRS, upright QRS in V5 and V6. So it is suggestive of a left bundle branch block. Questions that can be asked: what conditions do you see LBB, or in what conditions would you see this kind of a thing? Most commonly seen after myocardial infarction or coronary artery disease. And how do you manage left bundle branch block? What are the precautions that you need to take? If a patient has any bundle branch block, what are the precautions you will take? Sorry? No, okay, that of course is there. Anything else? What is it? Suppose a patient post MI develops sudden onset left bundle branch block. What can happen? Beta blockers should be very carefully given in these patients, and this can suddenly degenerate into a more complex kind of a rhythm like a complete heart block. So a fresh onset LBB should always alert you to the possibility of an underlying coronary ischemia. This is a very frequently kept question. What is it? There is a normal beat, there is a ectopic beat. Multiple VPCs, but they are in a rhythm. There is one normal, there is one VPC. One normal, one VPC. So it is a bigeminal rhythm. Okay. One normal, one VPC. One normal, one VPC. So this is a pattern of ventricular bigeminy. So questions that can be asked: again, in which situation would you likely to see a ventricular bigeminal pattern? It can occur in acute myocardial infarction, it can occur in pulmonary edema. Digitalis toxicity is a very important thing, you must always remember. But sometimes they may show you just a single one or two occasional VPCs. They may not be in a bigeminal pattern. So even then they can ask questions like, suppose it's a 70-year-old man just showing 4 or 6 VPCs in the ECG, what do you need to do? Yes, so it depends whether or not there is underlying structural heart disease, whether or not there is hemodynamic compromise. So these are things that need to be kept. So in elderly patients, up to 20% of patients can have isolated VPCs. Okay, but what are the things that you need to see? Whether there is an R on T phenomenon which is likely to show that it is likely to degenerate into a more complex rhythm. Okay, right. What is happening here? Ventricular tachycardia. We saw supraventricular tachycardia, which was a narrow QRS tachycardia. This is a broad QRS tachycardia. So this is invariably kept for almost everybody. All of you must see one example at least of an ECG of VTach, because the questions that will be asked are: in which situation are you likely to encounter ventricular tachycardia? How do you manage ventricular tachycardia? You must know the management of VTach, definitely. when will you give DC shock, how much DC shock will you give, how many times will you give. Suppose DC shock facility is not available in a primary health center, what can you do, what are the drugs you can give, what dosage you need to give these drugs, and what is the indication of a pacing in these patients. So these are questions that you must be very well aware of. You must know everything about ventricular tachycardia, right? Okay, we can see here what is happening is, these are the, if you take the long lead, these are the QRS complexes, okay, and the smaller ones are the P waves. If you see that there is no, yes, there is no association between the P and the QRS. P is moving at its own rate, QRS is moving at its own, so complete AV dissociation, okay. So in which condition are you likely to see complete AV dissociation? Acute myocardial infarction, especially inferior wall. And suppose if it is occurring in the situation of inferior wall MI, what do you need to do? You need not do anything. Actually, if you want, you can put in a temporary lead, but generally in inferior wall settings, a complete AV dissociation reverts back to itself on normal. But if it's in the setting of an anterior wall MI, you will probably need to do a permanent pacing in these situations. I am coming to my last two slides. Yes. What can you see here? Tall, peaked, tented T waves. Differential diagnosis? Hyperkalemia. Acute MI also, but there are no reciprocal changes, so we probably think it is peaked tall T wave seen in hyperkalemia. And my last slide is, what is this? This is hyperkalemia that is really very, very severe. You can see these almost large, bizarre QRS complexes almost going into sine wave pattern, which is suggestive of very severe hyperkalemia. Okay, so I think this was my last ECG slide that I had to show you. Okay, so to what we have learned today is, we have learned how to see specimens, and we have also seen how to see some ECGs. Most of them are kept as part of your spotting, where you will be either kept, it will be there in front of you, and there will be some questions which you will need to identify and answer those questions. Always spend some time, whether it is an ECG, whether it is a specimen. Don't get flustered if you see a specimen which you are not able to identify. Just spend some time, you should be able to see specimens. Most of you, if you are associated with hospitals where there is a pathology museum, please go down to your museum on one day and just see specimens, okay, cut sections or other whole organs, and then you should be able to see it.
With this, we come to an end to today's session.
Second is smaller in the size,
Yes.
and third is it has a guard.
Yes.